Hello, welcome to the first Academy for Healthcare Science webinar. I'm Jane Tovey and I'm the chairman of the Institute of Medical Illustrators, and I have the great pleasure of being host of this event. COVID-19 has seen a massive spike in the use of DIY photography, as the number of professional clinical photographers may well have reduced alongside other NHS personnel, but the need for photographic evidence continues to increase beyond all measure. It is all too easy to whip out a mobile phone, and especially when the government in a major incident, it's certainly permissible. As a consequence of this, trusts across the country may be trying to manage silos of sensitive clinical data that you might not have had to concern yourself with previously. Today, we hope to help you and 99 other delegates who have joined us today in answering some of those concerns. I would now like to introduce you to our panel, and then Anthony will give us a short presentation sharing his screen, and we will end up with a few questions at the end that have been submitted prior to this day, and hopefully we can open up the chat function if we have time at the end. Other than that, you'll be able to email us with your queries. Thank you. So the panel. Now, let me introduce you to who we have as experts today. Firstly, Carol Fleming. She is the Secretary of the Institute of Medical Illustrators and has recently retired from her post as Medical Illustration Services Manager at Bradford NHS Trust. She was also leader of the Working Party on registration for clinical photographers. Carol led the Bradford department to be the very first to be ISO accredited in the UK and maintained ISO 2001 for more than 18 years. Her key interests are regulation, quality development, systems design, audit, and patient information. Carol was also part of the team preparing successful bids to the Health Professions Council for statutory regulation in 2003 and accredited registration with the Academy of Healthcare Science in 2017. Cathy McFall is Education Lead for IMI and Medical Illustration Services Manager at Greater Glasgow and Clyde Health Board in Scotland. She is a former editor of the Journal of Visual Communications in Medicine and a past president of the Health and Science Communications Association, HESCA. Cathy is also an honorary lecturer at the University of Glasgow and has recently co-authored the IMI Confidentiality and Consent, a Guide to Good Practice. Anthony Edwards is IMI's regional representative for Ireland and service manager at St James's Hospital in Dublin. Anthony, as service lead, has overseen the transition from traditional photography into the fully fledged digital service it is today, and in the process has seen referrals for clinical photography increase tenfold, and the transformation from being a teaching aid to being an important element in the treatment pathway. Anthony has a keen interest in data protection and was lead author of the Institute of Medical Illustrators guidance on mobile phone and mobile apps for the clinical photographer. So over to Anthony for today's presentation. Thank you.
Thanks very much, Jane. Hope everyone can hear me. Get my slides organized. So, as Jane said, my name is Anthony Edwards. I'm the senior clinical photographer at St James's Hospital. I've been based here for the last 17 years, and there's no doubt the last 12 months have been very different to any of the years that went before it. So COVID has had a huge impact on how we do things in a hospital, and that's been the same with clinical photography as well. Personally, on our service, we've seen some positive developments on that, and that our referrals have increased again, and our sorry, just changed my mic here. So our referrals have increased, and I would also say that our kind of standing in the hospital has increased as well over the last 12 months. So what I'm going to start off with is just giving a quick introduction to those of you who aren't very familiar with clinical photography. So clinical photography is basically involved in capturing images of patients of their condition at a particular moment in time, and where it becomes,
if I forward that on,
just the ability to take serial images or to capture patients over a period of time. So as a clinical photographer, we're always interested in photographing patients with the same views, same position, same lighting, same magnification, and that way you can really show the progress of a disease over time. The only thing we want to see change in our photographs is the patient's condition. And what are photographs used for? So clinical photographs, as Jane said in the start, are primarily used as part of our treatment pathway now in St. James's. So whether that's wound management or preoperative planning and various things like that. They're used in education, both of staff and students, the medical students and lives. They're used for clinical trials and in other research projects. And they're also used for legal purposes. So whether that's to protect the hospital from litigation or personal injuries or criminal cases as well. So who's photographing patients in the hospital? First of all, you've got your official photographers. So those are of us who are employed by the hospitals to photograph patients and the departments that are involved in that. And you have your unofficial photographers. So unofficial photographers is anyone who's not a clinical photographer, but it may include GPs or patients who are sending images into us. It may include out of hours arrangements to capture patient images when clinical photography departments aren't ready. But what we're really interested in today are clinical photographs that are captured by all members of clinical teams on personal devices that we don't really know a whole lot about, that we're not managing, and that we don't have any control over the images they're taking or how they're stored. There was a study going back a couple of years ago among orthopedic surgeons, and it found that 100% of them had smartphones at the time. 91% of them admitted that they had patient images and videos on their phone, and 79% admitted that they photographed unconscious patients without consent in theatre. So this might sound a little bit familiar. This photograph above was one my colleague took in theatre, and you can see here that there's a surgeon photographing a patient on their phone. There's several other staff in the theatre who aren't concerned about her doing this, and she's actually doing it right in front of her clinical photographer, so there were good quality clinical images available. But doctors in the habit of photographing patients themselves anyway, like to have them on the phone. So these are the types of clinical photographs that worry us. Mobile phones in particular, in terms of present a problem for data control.
right, okay.
A little bit in terms of one of the reasons why I think mobile phones have become a problem is how quick they've evolved over time. So I bought my first mobile phone in 1999, and the only thing it could do was make phone calls. A couple of years later, I had a phone that could also send text messages as well as making phone calls. And a few years after that, I had a phone that I could also take photographs on. The quality wasn't brilliant on these with these cameras, and if you wanted to share them with someone else, quite often they have to log into their email to download a multimedia message. They didn't always go phone to phone, particularly if the other phone didn't have a camera device. So where things really started to change was with the iPhone 3GS that was launched in 2009. The first iPhone was launched in 2007, and there's been 25 versions of it since. But the 3GS in 2009 was the first phone that connected to 3G networks. And it was also the first phone that kind of became freely available to bill-paying customers. So it's the first smartphone that kind of broke into the mainstream. And with it, it brought mobile applications. And applications were a new feature for us on our phone. And chief among them were instant messaging applications. So I'm sure everyone here is familiar with WhatsApp. It's a free communication tool that allows you to have group chats, send text messages, send images, send videos. Very versatile app. It was first founded in 2009, so just over 10 years old. By 2014, it had 400 million users. And by last year, it had more than 2 billion users worldwide. So you can see that it kind of reaches everywhere. So the kind of main point here is that the mobile phones that we started off with have evolved into personal communication devices that are always on. They've all got cameras, they've all got software that allows us to edit images and share images. And the big issue, I think, with mobile phones, there's a few. First of all, everyone on every team already has one, so they're not a cost to the hospital if people are bringing their own. They already have them, so they're cost neutral both to the hospital but also to the teams. I mean, if people have a mobile phone and they're using it, it doesn't cost them any extra to use it in work, to take photos or share photos, because all the applications are free to use. So it's become too convenient. It's a very powerful tool. Why wouldn't you use it? So enter GDPR. In May 2018, GDPR came live, and as a clinical photographer, I've kind of seen this as a big opportunity to kind of let people know about the dangers of using their phones and also the responsibilities in relation to personal data. So GDPR put the data subject at the center of the legislation. And there are several kind of aspects of it that were particularly interesting to me, the clinical photographer. So it has specific information around consent, about how images or data is processed, how it's stored, and how it can be shared. It also has the right to be forgotten, which is an important one as well, in terms of if doctors are generating data on their phones, that their subjects have the right to be forgotten if they wish. So if you look at consent, first of all, as clinical photographers, we'd be always used to taking consent from patients, and traditionally our consent was based around how the images would be used. So whether they were for medical record only, if they were to be used for teaching, or if they were available to be used outside of the hospital for publication. So whether that's speaking at a conference or publishing an article. So we were well used to the consent side of it on the photography point of view. But GDPR kind of indicates that the consent has to be clear and concise. It has to be a positive opt-in for the subject. So you can't present a form to them where you've already ticked the levels of permission that you want. They must tick those boxes themselves. You have to keep evidence of the consent, and the data subject must have the ability to withdraw that consent if they change their mind. So just on the consent one, I quite often see doctors taking out their phones and approaching the patient and saying, I'm just going to take a quick photograph of this. They think they're getting permission to take the photograph, but it's not consent in terms of what they're going to do with the photograph, where they're going to save that photograph, if they're going to share that photograph. So they're really not getting consent, and they certainly don't have any evidence of the consent. And as we've seen in the earlier example, quite often their patients aren't conscious either, so the consent is not possible. Another interesting aspect of the GDPR was to distinguish between data controllers and data processors. I guess in a simple way of looking at it, most people might assume that the hospital is a data controller and that it's a member of staff who processes data that becomes a data processor. There might be some kind of debate on that in some circles in our hospital, that you're not allowed to photograph patients on your own personal devices. So if you look at the definition of what a data controller is, they decide what data is captured. They decide how it's stored and how it's processed or shared. So if you have a doctor who takes a photograph on their phone, they're deciding to capture that data. They're deciding that they're saving it on their phone. And if they later share it with their team or with other colleagues, they're deciding how to share it. So I quite often make the point when I speak with the medical teams here is that they are the data controllers on the data they're capturing on personal devices. And that's significant because the penalties involved for a data controller versus a data processor is a little bit different. On the storage and sharing of personal data, the GDPR indicates that data should be kept secure at all times. It should only be used in keeping with the original permission, and that sensitive data requires additional secure measures. Now, this is very important from clinical photography point of view because medical records are considered personal or sensitive personal data, and clinical photographs are particularly.
I will, yeah.
This because photographs are a little bit different to most medical records in that members of the public can probably quite easily digest or interpret most of the images that we would take. So if you had an MRI or a page from a chart that went missing, there's a good chance that it wouldn't mean anything to a member of the public. But if a photograph ended up in the public sphere, there's a good chance that a lot of people, A, might find it curious, or B, would completely understand what's going on in the photograph. So that's why we're particularly worried about clinical photographs. On the security side of things, then, there is a big responsibility to keep personal data secure, but mobile phones are probably the least secure thing that you can keep data on. I have another quick study here from a pediatric hospital in Dublin, and they were looking at people using WhatsApp for sharing information. So 100% of them said that they did use WhatsApp to share information on the team. 97% of the respondents in this said that they had sensitive data on their phone. And probably the most alarming of all, 30% of the people questioned had lost their phone in the last 12 months. Now, I've never lost a phone myself, but I can only imagine the panic if you've got some sensitive images on your phone and it goes missing. I just have a little slide here to kind of maybe illustrate how sensitive images can be. This was from the Irish Times. It's from an inquest in 2017 from a patient who passed away in the hospital I work in. And in this particular case, the patient had undergone a thyroidectomy, and the intern on call, who was newly qualified, was a little bit concerned that they were having difficulty breathing, and they contacted an ENT registrar on call. So the ENT asked them to send on some images of a drain that had been inserted that they could check if it looked okay. Now, what's particularly interesting to me on this story is that the fact that the doctor looked for mobile phone images of the patient was the headline, but it's not mentioned at any point during the article. We've read the entire article, but the photographs didn't play a pivotal role in this case, but they became the headline. And I always kind of use this as an example that if sensitive patient images was to end up in the public realm, it will make headlines very quickly. So what do we need to do on this? We need to get control of the images that every member of staff is taking in the hospital. It's a difficult thing because you don't know who's doing them, but there are a couple of methods by which we could try to do that. First one, I've a few apps here on the screen that most clinical photographers would be used to. These are 3 apps that are designed to capture patient images, and they each have a method of linking the images to the patient and linking the images to the hospital's existing clinical images archives. So this is a kind of method whereby if you roll this out, you could allow people to photograph when necessary in an emergency or out of hours. It records the consent and it connects the image to the patient, and this is kind of mainly what we need to try and do with these type of images. So firstly, we have to connect them to the patient so that we don't lose them. We have to record the patient consent so we know what the patient was happy for those images being used for. And if you're using any app, it has to allow for those images to end up in the patient record or in the clinical image archive. Ideally, if there's a third-party app being used for this, it would have two-stage authentication. In other words, that if a member of staff is using it to capture images, that they would need a second authentication to log into that app. So preferably that would be biometric in terms of a fingerprint to get in, so you couldn't have someone else who knows your code to your phone getting into it. Okay, so to put a little bit of COVID-19 context on it, but going back to last March when COVID kind of really hit our hospital, there was a couple of things that we noticed as clinical photographers pretty early on. First of all, there was a little bit of concern on the amount of PPE available. So there was a definite drive to reduce the amount of people who are having contact with patients. So that was partly to preserve PPE that not everybody would put the PPE on to go in. But and also then a natural kind of caution in terms of what we didn't know about COVID, and people, if they could avoid going into a room with a COVID patient, they would. So what we found early on is that members of the teams were using phones to photograph the patient so they could then share that with the rest of the team, so it meant only one person went in. And pretty quickly we start having feedback from nurses that medical teams were asking the nurses to take photos of patients and send it on to them so they didn't need to come to the ward. The nurses themselves weren't very comfortable with that, so as a result of that, we've seen a big increase in the requests for our services. So whenever a team are looking for a photograph of an inpatient, the nursing staff would make a referral to us, and we go do it. So that was kind of, I guess, partly at the start when I alluded that there were some positives for our service. We've seen a huge increase in the amount of clinical photograph requests we're getting on inpatients. On the flip side of that, our hospital also rolled out a free messaging app that was designed to improve communication with all staff during the COVID outbreaks. So for staff who don't have access to email or aren't at a computer during the day, that they would have an app on the phone that had updates. And it was quite a good communications tool. But the problem that we kind of seen with it pretty quickly is that the hospital essentially were that this silo as a secure messaging app that was designed for medical teams. So the teams started using it relatively quickly in the same way they would use WhatsApp.
Go to file preference.
On thinking that this was a secure way of them sharing images. So there's a couple of features to Silo that were kind of sold as being benefits. First off, that it does require two-stage authentication, but I found myself when I downloaded it that I had to go into the settings and change that to biometric. The default was for it just to be a code. And I think most people who have an unlock code on their phone most likely decided to use the same unlock code on the app. So that kind of more or less removes the security on the app straight away. The other feature that was sold as a positive, but I myself would find quite alarming, is that the chats and Silo erase after 30 days. So from a data protection point of view, I find this very problematic. So if you have teams who are photographing patients and sharing images and assuming it's secure, I'm happy enough maybe that it's deleted at a later point if we're looking for that data. You know, how do we get it? I had a case a couple of years ago of a patient who came into our emergency department and was photographed. They subsequently died, and there was a murder trial on it. And at the time, there was a big push to get the images that were taken of this patient while they were in the emergency department. The official photographers hadn't taken it in the hospital, so all we could do is assume that one of the doctors that had come in contact with this patient had taken photographs. we eventually tracked it down to a doctor who was no longer working in the hospital. She had moved on to another hospital, but she had deleted the photos from her phone before we got a chance to get them. So the photos themselves could have been quite pivotal in an important case. So again, this kind of, for me, kind of illustrates why an app like Silo, while looking that it's purpose-built for medical use, actually is a disaster for data protection. So just finishing up here on in terms of the information I'm going to give you, and I just wanted to kind of finish with a little bit of a positive on this. So you might assume that as clinical photographers, we've seen smartphones as being the enemy, and that they certainly have impacted some departments negatively. In my own experience, from when smartphone, or particularly that 3GS phone launched in 2009, our referrals have gone through the roof. I think this is largely down to the fact that the medical teams have gotten used to how useful an image can be in their treatment pathways. So there's all sorts of specialties who now routinely call us for photographs that prior to 2009 never thought of calling us for photographs. It's also an indication, I think, that photographs are being used much more in the treatment pathway and less for educational use. When I first came here, let's say I changed over from an analog to digital photography system, and on analog, everything we did was largely geared towards teaching, whereas that has changed now, and as I say, the teams are well used to how valuable an image can be in their treatment pathway, and hence why they're fond of taking photographs themselves. Okay, so that's the end of my presentation.
Okay, I think it's back to me, technology. I just want to say a huge thank you to Anthony. That presentation I first saw at a conference, at one of our conferences. It lasted an hour long, and it was full of jaw-dropping facts. So I thought he was the perfect person to present to you today. As I said, you know, it's normally a longer lecture, so he has truncated it for you into this small package. So we hope we gave you a flavour. We have actually received some questions before the event, and so I'd like to go on to answer those. I appreciate that you all may well have some questions yourself, and what we'll do is we'll use the chat function, and I'll give out an email at the end, and you can send them through, and we'll pick them up that way. Okay, so first of all, I'm going to ask our panel to reveal themselves, if that's possible. Our panel can come up onto the screen. Thank you. Lovely. And the first one I think is most appropriate for Kathy. And this might be said by some of our accountants, perhaps. Why does someone taking clinical photographs really need a degree in medical illustration when you can get a half decent picture with an automated camera nowadays? Over to you, Kathy. I think you're on mute.
Can you hear me now?
We can. Well, I can.
Thank you.
Yeah.
I think that's a fairly easy one to answer from my perspective. If you took anything in from Anthony's presentation there, I hope that demonstrates there's a lot more to taking a photograph than just pressing a button. I suppose I would also allude to the fact that a degree takes years, and in those 3 years for a general photography degree, you learn a lot more about what's involved in capturing an image and the technical skills that can sit behind that, specifically when you're looking into the healthcare environment. So I don't think it can be compared to somebody that just presses a button. I think what Anthony also demonstrated is at times there's probably a need for that. But in terms of education for those that undertake a degree. So they do a 3-year photography degree, and then they would do an additional year postgraduate certificate in clinical photography. They're learning about those legal and ethical considerations. They're learning about anatomy and physiology. And I think most importantly, it's the technical skills for making the clinical images that we capture as diagnostic and as clinically valuable as possible. And I think we always try to push the boundaries as clinical photographers. How can we make our photographs better? And as I say, more clinically diagnostic. We have lots of techniques. We do 3D photography, 4D photography, dermoscopy, and these all add value to that clinical image, to that end product. I suppose the thing I would say is look at the journey when you take a clinical photograph. It's not just about pressing that button. It's about the request and the consent. What we really have to talk about is the ethical issues around capturing these images. Once you've captured that images, where does it go? Is it the best image? Is it the most diagnostic images? Is it reproducible? Then where do you store it? Then how do you retrieve it? And then all those secondary uses that Anthony mentioned about teaching, publication. And you also have to think we are often asked to give evidence and sign off the photographs that we capture as a true and legal record. And again, that's just skills that you learn as a clinical photographer. So I hope that covers that question, Jane.
Brilliant, thank you, thank you. The next one, I think I'm going to point in Carol's direction. Why should we employ registered clinical photographers, especially as it's only a voluntary register?
Okay, well, I think there are lots of reasons, but 3 key ones. The first one is that patients, members of the public, expect all people who work in hospitals to be suitably qualified, and that they're in safe hands. Very often a clinical photographer will be photographing a patient in a fairly sensitive situation.
We ought to, Anthony, put
trust in clinical photographers. So I think by being registered, it assures patients and employers that the photographers are qualified, registered and up to date. I think employers need to understand that the people that they're recruiting are qualified and capable of the job. You will usually find that registered clinical photographers will be experts in consent and confidentiality of images, storage of images, will probably be the policy writers within their organisations. They will be experts in this. And in case the audience hasn't already realised, clinical photographers and information governance specialists really should be best buddies in trusts because their key objectives are exactly the same. We're here to protect patients' data. And the third reason that clinical photography should be registered is that practitioners want to be able to demonstrate that they're experienced, qualified, that they've signed up to a code of practice and a set of standards, and that they undertake CPD and are continuously updating their skills. So it's really evidence of all of that. And that's why we recommend that any medical illustrators who are patient-facing should be on the Academy's voluntary register.
Brilliant, thank you, Carol. My last one, again, is following up from Anthony's talk. A question came in. There are lots of secure apps that medical teams can use to take clinical photographs. What are the pitfalls in using them? I know you touched on this a little in your talk.
I think kind of where there can be a little bit of confusion is that you can have an app that has end-to-end encryption. So WhatsApp, for example, is encrypted end-to-end. But once the data gets to the other end, there's no security on it. So like the encryption end-to-end will more or less mean that it can't be intercepted and decoded. But if the information arrives at the far end, anyone who's able to open somebody's phone can usually open their WhatsApp without there being any secondary kind of connection into it. I know in my own experience, I have a 5-year-old at home who can unlock my phone and often goes looking through the image library on it and will send texts and things on the phone. So if you're having a secure app, it needs to have biometric controls to get into it, i.e. that the person who's signed up for this, the only person who can get into that. From the data point of view, as someone who manages images that are taken from patients and from GPs and the likes, what we always want to do is get that data into our system as quickly as possible. So that, as I say, the apps I kind of highlighted there are all ones that have a workflow that will allow you to capture images and to tie them to the patient. It's not unusual if clinical staff comes to me with a digital camera or with a phone, that they might have 20 or 30 patients in a row, but they've no identifiers in between them. And you then have a job in a particular case that they're looking for the images on. They usually know who they're looking for. But down the road, if you were to ask them to identify who the patients were in these images, quite often they wouldn't be able to. So I think from a clinical photography perspective, that's a real key, that you're able to connect that data with the patient, and then have a method, as I say, for getting the data from that app into your hospital system so that it can be stored securely. The other kind of side of that is that with big technology companies, we don't know where they really save the data that they have. So, I mean, let's say that Silo app I highlighted, say that a conversation will delete after 30 days. I'd be highly skeptical that they don't still have it somewhere on a server. And, from as being in the Republic of Ireland at the moment, if that data is outside the EU, then that's against GDPR from our perspective at the moment. So I think from that point of view, you really need dedicated purpose-built apps. I don't think there's any off-the-shelf apps that are going to do it without being configured to work with your hospital system.
Thank you, Anthony. That's marvellous. So that's our final presentation and the questions we had in advance. Thank you very much for joining us today. I hope it's been of interest. If you have any questions, please don't hesitate to contact us. We are going to try and use the chat function, but we can export that chat and respond to those individually. If you want to use an email, if you'd like to email inquiries at imi.org.uk, and that will come through to this team, and we'll be able to answer your questions directly. So finally, I would like to thank the Academy for Healthcare Science for giving us this opportunity to host this webinar for you, and to thank you for turning up in your lunchtime, very busy day. Have a good weekend, and goodbye on behalf of myself and my fellow IMI panel members. Thank you.